enzalutamide, denosumab, or zoledronic acid. Okay. Let's see what we get. Okay, we have one respondent. More seconds. Anybody else want to jump in? It's evening out. It's a race. All right, there you go. Let's call it when it's even, because I think that that's fair, right? Apalutamide was FDA approved first, enzalutamide just got FDA approved in this setting. Denosumab had a positive trial, but not positive enough for the FDA to approve it. Zoledronic acid, they never even completed their study because their assumptions were wrong. They were statistically underpowered. So here's the data published in the New England Journal recently from the Spartan trial. This took patients with M0 castration-resistant prostate cancer with high-risk features. High risk defined as PSA doubling time less than 10 months, although 75% of the patient population had a doubling time less than 6 months, so very high risk. Primary endpoint was metastasis-free survival. You see the dramatic difference there. Forest plots almost all to the left, except for the African-American patient population, which was a very small subset. They also looked at some clinically relevant events, including symptomatic progression, and it was also significant for apalutamide over placebo, and also overall survival, which was not quite significant, but pretty close, but it's a real early look, okay? And recall apalutamide was developed also by Charles Sawyers in the same lab, biochemically just slightly structurally different than enzalutamide, but might cross the blood-brain barrier less, might have fewer neurocognitive side effects, but it's really hard to say, I can't tell. There is rash with it, that's a consideration as well, and of course falls and fractures and restless leg syndrome, the same things you get, and also enzalutamide. In the Prosper trial, this was a similarly designed study for the M0 CRPC patient population, also statistically significant with metastasis-free survival. Very nice forest plot here. And they looked at other measures of efficacy as time to first anti-neoplastic therapy, which was significantly delayed. Don't you love in prostate cancer how much we have separation we have between the curves? That's nice, but not overall survival. But this is early. Also, first interim analysis. We'll see what the final analyses show. But the primary endpoint was metastasis-free survival, and obviously both these agents are FDA approved now. So I'll wrap up now. Key take-home points: docetaxel and now also abiraterone each individually offer survival benefit for metastatic hormone-sensitive prostate cancer patients. Platinum chemotherapy has an increasing role in this disease, not just for neuroendocrine small cell, but also for patients with DNA repair deficiency. It looks like a 12% germline risk for those with metastatic prostate cancer, and genetic counselors can have a very important role. Unfortunately, we are significantly under-resourced and understaffed with genetic counselors, so it's a great profession to go into because there's going to be only increasing need. PARP inhibitors may have efficacy in this disease. There are many ongoing trials. Pembrolizumab is FDA approved for solid tumors with microsatellite instability, and it happens in prostate cancer, probably 5 to 10%, and both apalutamide and enzalutamide improve metastasis-free survival.